Hi, I'm Professor Zoe Winters. A pleasure to be on Dr. Fi. I'm a senior consultant breast cancer surgeon and professor of breast surgery at UCL, honorary, and I'm here to really help answer any questions. And I think one of the things that we commonly hear in central London, where my practice is based, is, do I always have to have a mastectomy? And let's take that. This is quite a complex arena because, of course, women have choice. I think we need to clearly say in one word, the answer is no, that mastectomy doesn't confer survival advantage of its own accord. So those women whom we recommend a mastectomy would be very specific. The very specific indication would be if you are considered high risk and carry a high risk gene. Many of you know the names of some of those genes. They may be a BRCA1 and 2 as a more common phenomenon. Then you may get rarer genes. I can give the names of those, but effectively we test for them. These are genes that suppress cancer development. So the P53 gene means you could have cancers in your family at a very young age. The P10 gene means your growth factor pathways are active, and this is part of something called Cowden syndrome. And then you get a gene called STK11 or CDH1, which is even linked to gastric cancers and lobular cancers. So in those settings, we are recommending either a risk-reducing mastectomy, but where you've already been diagnosed with a breast cancer, clearly a mastectomy to treat the affected side. We would also plan to use a simultaneous contralateral mastectomy as part of the risk reduction, and of course offer women the option of immediate breast reconstruction. So if you have small cancers are good, and good because they're small. They're usually detected by screening on imaging only. That means we have a 10 to 20 year clinical advantage. There is no survival advantage in mastectomy. And that is because we have precision localization surgery that involves an in-depth discussion with your consultant surgeon. Plus, we have radiotherapy that is now de-escalated into a few days, i.e. 5 days in a week. It may de-escalate more, whereas if you're 65 or 70 plus with a very small cancer, you may not even need radiotherapy. Furthermore, we have drugs. The medical aspect of the cancer is key. It often can be even more important because it targets the genes that drive. In an estrogen positive, we have outstanding drugs that lower risk significantly so that recurrence is 0.1% per year. It's cumulative over time. We need to be aware, however, that in low-risk cancers, we must maintain imaging. We can get recurrence 10 or 20 years later, but we can predict for this. And most of the predictors relate to the size or the appearance of the cancer, or whether you had nodal involvement. So it's really a composite picture. And that's why it's so important going to a specialist who's extremely experienced, who has seen where we've had complexity or recurrences, where the understanding has evolved tremendously in terms of medical therapies. And in cases that are difficult to decide whether we should give chemotherapy first, we seek that oncologist's opinion within the multi-team meeting. So there will certainly be women we can drive down the stage of the cancer and still save the breast by using upfront chemotherapy. So all of these things speak to enhanced survival. And we have many big population studies across Scandinavia and also in the US and UK that support survival advantage in breast conserving surgery combined with radiotherapy. Now, we don't understand why. We do understand that there are many confounding factors in the population. And some of those things we've even talked about. Women's population risk score, which most women don't know. We only know when a cancer occurs. In a sense, it's declaring they probably have a population polygenic risk score that makes them at elevated risk or high risk. So that's very different to a very high risk, which is only 2% of the population. So the radiotherapy, the medical therapy, and achieving microscopic clearance. If a margin is positive and it goes undetected because it's either adjacent to the skin or to the anatomical chest wall, is cautionary. We will always do extra imaging. We are aware that skin margin positivity can increase risk, and so can positivity to the chest wall. So we are mindful of giving extra doses of radiotherapy and making sure that our screening is enhanced and our clinical reviews are maintained.